Thank you, John, and thank you for the welcome. And really, it's a privilege to be back with you. It's not often that you get invited to come back, give the same talk, and get filmed. So I'll take it and with gratitude. But I'm grateful for the opportunity because I think the issues that we want to discuss this evening are crucially important to thinking about how we practice medicine. I'm interested to know, how many of you here are first-year med students? Okay, a few hands, all right. Second year? Third year? Fourth years? Residents? Okay, so we've got a really nice distribution around the room of people at different stages of training. But the truth is, I found during my clinical training, whether it's med school or residency, that you're so busy just trying to learn all the technical competencies that are required of a good physician: diagnosis, physical diagnosis, clinical reasoning, surgical skills, all these kinds of things that you have to be able to do to be a good doctor, that it's difficult to take time to really understand why you're doing what you're doing when you're doing it. And it's only after you really get into practice and you begin to wrestle more and more with difficult individual situations that you're forced to really begin to think about the philosophical issues that underpin our approach to the way we take care of patients. And essentially, this evening, what I want to do is I want to make an argument. And the argument goes as follows. Number one, worldviews profoundly and unavoidably influence medical decision-making. Number two, there's no good reason for secular humanism to be the default position over against Christian theism or any other worldview for that matter. And thirdly, therefore, it's reasonable, at minimum, for your Christian faith to influence the way that you practice medicine. And a corollary of that is that it's reasonable for your patients to make decisions about their care in light of their own worldview. And how we handle and respond to the conflicts that arise as a consequence of these foundational disagreements becomes the challenge of being a good physician. Now, I have to begin with a disclosure. I'm not a trained philosopher, and so we're going to be talking about philosophical issues, but I have no professional expertise in this area, other than the fact that, like any diligent doctor, I think that we need to read a lot and think hard about why we're doing what we're doing so that we can be able to defend it, at least, and explain and make the case for why we take certain stances that we do. So, without further ado, let's begin. So, first of all, I want to argue that worldviews profoundly and unavoidably influence clinical decision-making. So what's a worldview? Well, very simply, it's a set of foundational beliefs that sort of shapes the way that you look at the world. Postmodernists like to refer to worldviews as meta-narratives. I'm sure you've heard of that term. It's the big story that we tell ourselves about who we are, where we came from, why we're here, where we're going, sort of the big story that we tell ourselves about what the world is about and what it's like. James Sire, who wrote a wonderful book on worldviews called The Universe Next Door, defines a worldview as a commitment or a fundamental orientation of the heart that can be expressed as a story or in a set of presuppositions about the basic construction of reality and that provides the foundation in which we live and move and have our being. Tim Keller gives something more of a theological definition of worldview. He says that every human personality, community, thought form, and culture will be based on some ultimate concern or some ultimate allegiance, either to God or to some God substitute. So the point is that when we're trying to understand the way that people see the world, we need to understand that everyone carries around this kind of baggage that shapes how they hear things, how they think about things, what they think matters and what doesn't, and so on. We all have a worldview, and that worldview is primarily composed of some ultimate allegiance, either to God or to some God substitute, as we'll explain more. So, is there any evidence that these kinds of worldviews, basic foundational beliefs, influence the way that we practice medicine? Well, I think it's pretty obviously true when you begin to think about the kinds of belief systems that shape moral conflict in contemporary medicine. We're all familiar with some of the issues around conscientious objection and the challenge of practicing medicine as a Christian or as an Orthodox Jew or as a Muslim in the contemporary because of some of the expectations that are placed upon physicians. And you probably have heard about the court case where the Christian Medical and Dental Society, among others, sued the college because they felt it was an inappropriate and unfair imposition on conscience rights to be forced to refer for euthanasia, among other practices. And the interesting thing is that these kind of conflicts are always demarcated along religious lines. You won't find too many seculars, although there may be some, who feel strongly and passionately about refusing to make a referral. Whereas you'll find many Christians and many Orthodox Jews who feel very strongly about these things. And so this kind of gives us a hint that there are kind of deep underlying differences in the way that we see the world that drive this moral conflict in medicine. And there's empirical data on this, that the way that you see the world foundationally influences, for example, your end-of-life practices. So in this empirical survey published in the Journal of Medical Ethics, they found that non-religious physicians in the United Kingdom were more likely to support legalization for euthanasia, more likely to have administered terminal sedation, more likely to have partly intended to cause death when providing palliative medicine, and more likely have discussed deliberately causing death with their patients. And these differences were profound, statistically significant and clinically significant, big differences in patterns of care between physicians who were religious and those who were not. So again, we see worldview seeming to make a difference in how we approach certain aspects of medicine. This paper, which some of you might remember discussing at the last presentation on the issue of worldview in medicine back in the spring, this paper introduced an interesting argument where these authors, really highly recognized academic physicians in the United Kingdom, argued that when you're writing about abortion or euthanasia or other morally controversial issues in medical ethics, that if you're a religious person, you ought to disclose that as part of your paper, because they're arguing that this functions as a kind of conflict of interest. It biases your view of the issue, and so if people want to understand where you really come from, then you need to be upfront about your worldview. So again, this is tacit recognition, although somewhat one-sided tacit recognition, that foundational beliefs play a profound role in shaping your approach to the practice of medicine. Now, the philosophy of medicine, as far as I can tell, and I haven't delved deeply into this area, seems to be a relatively young field, would be considered a branch of the philosophy of science. But the important thing to understand is that increasingly we need to recognize that medicine is a philosophical endeavor. And if you consult an introductory book like this, Ross Upshur is actually a professor of medicine here at the University of Toronto and a well-known philosopher of medicine. If you consult a textbook like this here, you'll see that philosophers wrestle with issues like, how do you differentiate between a disease state and a state of health? What exactly is health? What's normal and what's abnormal, and how do we tell the difference? Issues like causation and induction. How do you know that something really causes something else? These are actually very old philosophical problems. Issues of medical epistemology. What counts as evidence? What doesn't? Why does one thing count as evidence and another doesn't? Where should the authority for medicine lie? The nature of mental illness. What's abnormal and normal range of mental phenomenology? And what are the boundaries of medicine? What differentiates sort of sound medical practice from quackery? What's scientific medicine and what's not? These are all kind of very weighty philosophical problems that we completely take for granted on a day-to-day basis, but that really have profound implications. And just one example is the shift over time in the nature of biomedicine. In the early 80s, there was the introduction of the biopsychosocial model of medicine. More recently, there's been a shift towards what's called precision medicine, narrative medicine, all these different ways of looking about what medicine is and how it goes about being done. So my point is that medicine is a philosophical endeavor, and accordingly, these basic philosophical issues shape the way that we think about medical practice. Now that's all very abstract. How does this actually make a difference at the bedside? And there's this wonderful paper by a philosopher of medicine, Ewan Goligher, who spoke at the CMDS conference in the spring. And he has written about this and argues that your worldview has a profound influence on medical practice because it shapes your notions of health and human flourishing. So the point is that when a patient's thinking about, and you're thinking about recommending a specific test or treatment, you're doing so in light of particular goals that are trying to be achieved. And in the ICU, I don't know if you've had any exposure yet to palliative care or critical care where we have lots of end-of-life decision-making going on. Patients have to make a choice about what kind of medical interventions they're going to pursue in light of whether they're seeking sort of aggressive, heroic measures to try and remain alive as long as possible, or pursuing more comfort measures, trying to maximize quality of life at the end of life. So the goals of care shape your decisions about what tests and what treatments you want. But in turn, the goals of care are shaped by your values. What kind of life is valuable and what is not? What's important to you in life and what's not important to you? And in turn, that is directly related to what you think is sort of health and what's a state of flourishing, what's a life worth pursuing and what's not. And because there's so much diversity in how people see the world around these issues, for a given discussion about resuscitation or about palliative care, you're going to get many different answers and responses. And Ewan Goligher writes, communicating moral reason ought to uncover the assumptions that pertain to a wide range of moral concerns, such as concepts of health and disease, the meaning of suffering and death, the basis of personhood and dignity, the moral implications of human freedom, and the requirements of justice. So you can't really talk or explain why you're doing what you're doing as a physician without getting into your basic views about what's a person, what is the basis of the dignity of the patient, what does it mean to have autonomy, and where does that come from? These kind of, what's healthy and what's disease. These are really basic issues that we're taking for granted when we have clinical conversations. Now, underlying one's view of goals of care and values and health and flourishing, I want to argue, is your worldview. That set of basic beliefs that you have about the nature of ultimate reality. And in general, worldview describes what you think is the real, the true, and the good. So by the real is sort of like what is ultimate reality composed of. And so that's going to drive what you think a patient is. Is a patient a purely material object? Is a patient composed of body and soul? There's a fundamental distinction between the way that seculars and Christians would look at the patient. Your worldview is also going to shape your understanding of the true and how you go about deciding what's true and false. Do you rely entirely on human reason and experience, or are you open to other sources of knowledge? And are there any other reliable sources of knowledge? Then there's the question of the good, which obviously is very pertinent, and that in turn defines how you're going to think about what it means to be a good doctor, what it means to take care of the patient. Is being a good doctor all about entirely respecting patient autonomy, or is there something more to the good than merely satisfying people's preferences? What makes the patient significant? What makes them matter? Again, these are fundamental issues that derive from your worldview. So just a few examples of where these worldview conflicts come up. For example, sometimes in the ICU, I consult on patients who have end-stage chronic disease and who clearly will never recover and will never be able to be liberated from life support. They're never going to leave the ICU alive. And so we often sit down with those people and try to explain the situation and explain that given that life support no longer can achieve recovery, that we need to start thinking about comfort care and about withdrawing life support. But for some people, because of their worldview, they insist that no, this state of remaining ventilator dependent is a good goal to achieve in and of itself. So you're not just on life support in order to be given a chance to recover. You're on life support to be kept alive. And so for people who see, and often these are people coming who have Orthodox who adhere to Orthodox Judaism. And for them, simply having a beating heart is obedience to rabbinical tradition and law. And consequently, for them, that's a state worth pursuing. And so they'll insist, no, we're going to continue remaining on life support as long as the heart remains beating. And so for many of us who feel like that's not a goal worth pursuing because of our worldview, it creates this deep, profound sense of internal moral conflict about keeping someone alive perpetually on a machine, vulnerable to all the complications of being in the ICU and the suffering attached to that. But for the patient and their family, nevertheless, this is a goal worth pursuing. So you can see that fundamental differences in worldview shape notions of health and flourishing and the meaning of life. Another really profound example is the issue of brain death. And I don't know if you've been following this in the courts in Ontario at all, but there are major conflicts going on in terms of our understanding of whether a brain dead patient is truly dead. And the truth is that this has been a matter of debate pretty much since the concept of brain death was introduced in the 70s. But only in recent times, in Canada at least, has the concept been seriously contested. But the problem is that different people approaching the situation of brain death with different worldviews arrive at different conclusions about whether it's valid. So let me just very briefly explain. How many of you are familiar with the concept of brain death or have seen a brain dead patient? So clearly not everybody. So it's maybe worth taking a second to understand that in Ontario and many jurisdictions in the last 40 years, there has been a definition of death that we define according to neurological criteria. These are patients whose whole entire brain is dead. So they've lost cortical function, they've lost all function, including that of the brainstem. And so, there's a whole series of very rigorous tests we do in the ICU to confirm that this brain function is lost. There's ancillary testing that we can do to confirm that the brain function is entirely lost. But then when you go to the family, and the reason this concept was introduced was really actually to facilitate organ donation, because at the time, in the 60s and 70s, people felt a great deal of compunction about just procuring organs from living patients. They didn't want to kill somebody in order to get their organs. So the donor had to be dead. And by defining patients with whole brain death as dead, it was then ethically permissible to procure their organs for transplantation. So this was really the motivation behind the introduction of the concept of brain death. But interestingly, when you go and tell families that their loved one is brain dead, sometimes they really have a hard time coming to terms with the notion that their loved one is dead, because they see them lying there in the bed, they touch their skin, it's warm, they see the pulse, they see the blood pressure, they see the oxygen saturation. And of course, the only reason the patient's being sustained is because of the machines that are supporting them. But the point is that for them, it's very difficult for them to say they're actually gone, because it doesn't seem like the body is entirely dead. It doesn't seem like a corpse. And so whether or not a patient that has whole brain death is actually dead is a profound philosophical question that's going to be shaped by your worldview. And if, for example, you're committed to a view that the body itself, apart from the brain, is a living being that's sacred in the eyes of God, as many Orthodox Jews are, they will be very reluctant to have anything to do with the concept of brain death. And so this is really what drives this kinds of moral conflict in critical care and end-of-life care. And of course, how do you even go about answering that question? How do you even go about deciding how you know whether whole brain death is really death or not? I think we can talk later if you want about why, as a Christian, I think we can be comfortable with the notion, but even it's not necessarily so straightforward. But again, my point is that worldview is driving profound moral conflict in medicine. So let's just move on to the second premise. I've argued that worldviews profoundly and unavoidably influence medical decision-making. So the question is there a worldview that a doctor ought to adopt? And my argument here is that there is no reason for you in any way to feel like you shouldn't bring your Christian theism, if that's your worldview, to bear on the practice of medicine. And in particular, I want to argue that by showing that secular humanism doesn't have any particularly good reasons for it to be the dominant paradigm under which we practice medicine. Let me explain what I mean by that. So what is secular humanism? Well, the Council for Secular Humanism defines it as a comprehensive, non-religious life stance. It's more than atheism in the sense that atheists simply hold to the belief that there's no God. Secular humanists move beyond that claim to say, but we still have a whole set of beliefs about what matters, about life, and about meaning, and so on. So I use the term secular humanism because it's a sort of broader, more encompassing term. One of the fundamental tenets of secular humanism was expressed by Protagoras in the 5th century BC. Man is the measure of all things. And basically the idea is that we position ourselves as the ultimate authority to decide for ourselves what's good and evil, what's true and false, what's real and what's not real. And so it really puts humanity at the very top of the food chain, so to speak. One of the other important tenets of secular humanism is that humans are the result of an unguided evolutionary process. And I emphasize here not so much the problem with the idea of evolution, but the idea of the unguidedness of it. That entails that behind our existence there's no purpose, no built-in meaning, and therefore we have to decide for ourselves what our purpose and meaning is. That's a crucial feature of humanism. So humanists would say that ultimate reality is material. They're generally, almost universally, philosophical materialists. So the only thing that's real is the material realm. They would also say that ultimately what's real is impersonal. It reduces to atoms or subatomic particles, whatever the latest discovered one might be, the Higgs boson. But ultimately, reality reduces to some kind of immaterial or to some kind of material particle. And therefore is ultimately impersonal. They would say the truth is to be determined by human reason and sense experience. And I think most secular humanists in our time would adhere to the notion that the highest good is human well-being, but human well-being is essentially defined in terms of subjective preference, maximizing personal autonomy and the satisfaction of personal preferences. So these are really the kind of defining features of secular humanism. And this is really the dominant way of looking at the world in the Western Academy, at least for the last 100, 150 years. It's been highly influential. It will be the worldview that most of our colleagues in medicine, or many of them, will adhere to. And it is really the operating principle for medical ethics, as I'll show you momentarily. By contrast, Christian theism sees the world quite differently. And if you're familiar with the Apostles' Creed, that's essentially a statement of the basic worldview of Christianity. And there's a number of excellent books that I can point you to that briefly summarize the core features of the Christian worldview. But in essence, from a Christian standpoint, ultimate reality is God. So ultimate reality is personal and immaterial, sort of the exact opposite of philosophical materialism. At the same time, we believe that the material realm is real, but it's contingent or secondary, dependent upon God's continuously upholding it. So the material realm is real, but it's not ultimate reality. In terms of ultimate truth, accept that all truth ultimately derives from God and depend on revelation to substantiate truth. But because we believe that God has created us in His image and intended us to know and rule over the world that He put us in, we're also very confident in human reason and experience within appropriate limits. And for Christians, the ultimate good is God Himself, and the opportunity to walk in love and fellowship with God. These are the highest goods that we're in pursuit of as Christians. And so these are basically the core tenets of the Christian worldview. The point, as I've already tried to make, is that often ethical conflict that we experience within medicine, whether it's between colleagues or between physicians and patients, often derives from foundational worldview conflicts. And Tristram Engelhardt, a Greek Orthodox philosopher of medicine at Baylor, and really a very eminent Christian medical ethicist, has written extensively about these issues. And he points out that a characteristic feature of contemporary culture is that it is marked by persistent and foundational moral disputes. We are living in an age when we really have a hard time getting along because there's these profound differences in the way that we look at the world, whether this is in politics or in medical ethics, etc. This is the sort of characteristic feature of our age, he observes. He goes on to write that many of the parties to these moral disputes find themselves embedded in morally and metaphysically incongruent understandings of proper human deportment, the significance of human life, and the nature of human flourishing. This moral diversity will have divergent implications regarding end-of-life decision-making and the use of high-cost, low-yield medical interventions. These are some of the issues I've already tried to argue. And so many have argued that given this kind of widely varying pluralistic situation where we've got so many different ways of looking at the world, that the default stance should be the godless stance. And this statement was drafted by Udo Schucklenk and colleagues who prepared the Royal Society of Canada expert report on end-of-life care in Canada. This was the document that really created or granted ethical permission for the legalization of euthanasia in Canada. And at some point, Schucklenk and colleagues are wrestling with the issue that for many of us, we see humans as made in the image of God, therefore they're sacred, and therefore we're unwilling to deliberately cause their death. But Schucklenk argues the underlying premise, namely that all humans are possessed of dignity and virtue of a special relationship to a God, is, however, incapable of being used as a basis of public policy proven in the context of a democratic, multicultural, and multi-faith society that must cleave to the strictures of public reason in ethical deliberation. And public reason is actually a technical term that you may or may not have heard before. The idea of public reason is that it requires that we adopt or adhere to moral or political rules that regulate our common life that are in some sense acceptable to everyone involved in the community. So Schucklenk's point is we can't make decisions about how we care for patients based on belief in God because not everybody accepts this. So we have to adopt instead a secular standpoint, which he assumed to be consistent with the strictures of public reason. So the question is, do secular foundational beliefs satisfy the strictures of public reason? The point here is that secularism is not a neutral position. It is not one overarching way of looking at the world that allows everyone from different worldviews to stand together. Rather, it adheres to specific assumptions about the nature of reality that bias or shape it. So that when secular ethicists are writing about their ethical views, they should be disclosing their own secularism as a conflict of interest. And so just some of the assumptions that secularism makes in relation to medical ethics is, for example, that humans matter. And Schucklenk and others who argue that we should provide good reasons for why we adhere to the foundational beliefs that we do, make no attempt to argue that humans matter or that autonomy should be respected or that one ought to accept a particular account of well-being or flourishing. These are all basic assumptions that they adhere to without any argument whatsoever. And crucially, what I want you to see is that secularism is not neutral. Again, I'll quote Engelhardt. He writes that the ideology of autonomy and equality, even if it were to reflect the morality that all did in fact embrace, cannot be shown by social, rational argument to be the morality that all should embrace. There is no independent perspective from which this moral perspective could, in principle, be justified. And so secular humanists, in other words, are relying on foundational beliefs that they make no attempt to argue for, just as much as Christian theists rely on belief in the existence of God to serve as a foundation for moral ethics in medicine. So we're all on the same footing in terms of the fact that we're coming to these issues with philosophical baggage. John Rawls, who is really probably the most famous political philosopher who wrestled with these issues of how do we get along in community, in a pluralistic society in such a way that we can ensure that justice is done, that satisfies everybody in the community, even if we have fundamentally different ways of looking at the world. You may have heard of his famous argument for justice from the veil of ignorance. Anybody, I don't know if anybody has encountered that notion of how you define fairness philosophically. But Rawls himself, who's a secular, recognized that secular reason is reasoning in terms of comprehensive non-religious doctrines. And if you're coming at an issue from a secular perspective, you're engaging doctrines and values that are much too broad to serve the purposes of public reason. And so, consequently, these secular philosophical doctrines do not provide public reasons for adopting public policy on particular issues in medical ethics. Secularism is not neutral, even according to John Rawls. In fact, depending on how you define religion, many people who are not religious could in fact be understood to be very religious. And this is because a way of looking at religion broadly is that it represents a search for the real in light of some concept of the good, some concept of the real in the search for the good. This is essentially a way of describing a worldview. And if you think about religion in this fashion, if you define religion as, or being religious as one holding that something has to be more important than everything else, and one must relate that something to everything else in some sort of pattern of subordination, or if it's a system of belief that describes some ultimate reality and some ultimate good, you are in a sense religious. And I would really encourage you, if you can carve out the time, to go and read this article by John Reeder in the Journal of Religious Ethics. It's an old paper, but it's really honestly very worthwhile because he makes it so plain that even those who adhere to no belief in God whatsoever, insofar as they still live with some concept of the real and the search for the good, are actually religious believers. Reader writes, on this view of a religious vision, the worldview that says that reality consists of the material cosmos known through physics, matter and energy as ultimate element and power, would count as religious. Those who claim to have no religion are in fact deeply religious. So everyone's bringing their kind of religion to bear on these issues, and no one escapes this challenge of worldview. One of the most obvious ways to me in which secular humanism functions like a religion in terms of its support for euthanasia is the claim that it makes that a patient can be better off dead. I mean, there are two basic moral arguments underpinning the case for euthanasia. One is that one ought to respect patient autonomy. But the second necessary condition is that one believes that the patient is actually better off dead. That is, in respecting their autonomy, they actually end up, you're doing them good. But to say that you're doing someone good by ending their life necessarily entails not only some belief about what their life is like before they're dead, but also what it's like to be dead. Because if you're going to claim that somebody's better off dead, that's necessarily predicated on some notion of what it's like to be dead. And so many of our colleagues who are secular humanists would assume that death is non-existence, or I'm not sure what else they would believe. But the point is that they're engaging views about the afterlife or the lack thereof in arguing that euthanasia is a good thing to do. It's a deeply religious practice. Euthanasia is a deeply religious practice. It's a kind of religious ritual of secular humanism because it's evidences their beliefs about how one might use the afterlife to do good, or to use death to do good. So again, secularism is not neutral. Loris Caligan writes, in the context of ethics, it's not appropriate to draw a line between one set of beliefs labeled religious and another set labeled philosophical, because in doing so, one fails to appreciate that beliefs under either of these labels serve similarly foundational roles in ethical reasoning. So I've argued that secularism is as religious as Christianity in terms of the role it plays in providing a foundation for morality in medicine. But the question is secularism even a good foundation for morality in medicine? I want to very briefly argue that it's not. First of all, secularism is self-refuting with respect to the belief in patient value. And secondly, it's self-refuting with respect to the belief that we can know something as physicians authoritatively that we're doing good to people. So first of all, value. Under the secular ethos, personhood and value primarily derive from the possession of certain functional capacities. Principally, and all are essentially related to your ability to express your autonomous wishes. Increasingly, the possession of autonomy, the possession of consciousness, the possession of sort of preferences and desires is felt to be some sort of minimum for the possession of personhood. So you can be a human, Homo sapiens, but if you have lost those features, then you're no longer a person. Or if you have not yet gained them, you're not yet a person. And so autonomy is really a central notion under the secular ethos. But autonomy basically means this idea that you have a free will, you have desires, and you exercise that right of self-determination. But the problem is that if you're a materialist, that actually entails determinism with respect to mind, because under materialism, your brain and your thinking all reduce to neurochemistry. You are nothing but your brain. Your thinking is nothing more than the firing of neurons in a very carefully regulated process. And that firing of neurons is reducible to physics and chemistry. So in theory, if the material philosophical worldview is correct, you should in theory be able to describe someone's entire thought life in terms of physics and chemistry, and even it should be essentially predictable in relation to the physical chemical events that have gone before necessarily driving those that come after. So if materialism is true, then physical determinism is also necessarily true, and many secular philosophers have argued actually that there's no such thing as free will, including the well-known atheist Sam Harris. He wrote a book, Free Will, in 2012, where he wrote, "How can we be free as conscious agents if everything that we consciously intend is caused by events in our brain that we do not intend and of which we are entirely unaware?" We can't. So the conclusion for the materialist is that there is no such thing as free will. That also entails that there is no such thing as autonomy, which then, under the secular framework, entails there's no such thing as a person possessing any characteristics worth talking about in terms of personhood. So secularism, this worldview, is self-refuting in terms of its belief, claims about patients having value. A second area where secularism is self-refuting is with respect to the ability to know truth. So for example, to diagnose illness, or to reliably predict outcomes, or to know that a certain treatment will meaningfully affect outcome. In all of these kinds of medical scientific endeavors, human judgment and reason are inextricably involved in deciding what's true and what's false. And the point I want to make here is that if secularism is true, you have no reason to be confident whatsoever that we could ever arrive at true conclusions. And here's why. So again, if your brain is the product of an unguided evolutionary process, then its belief-forming mechanisms are entirely engineered toward maximizing survival, and rather than being engineered towards forming true beliefs. If it's the case that physics and chemistry are entirely responsible for the beliefs that you form, and those physics and physical and chemical processes have been guided entirely by materialistic mechanisms operating over long eons of time, then the question is, what is the probability that any of the beliefs that you ever form would have anything to do with truth rather than merely functioning to maximize survival? The simple truth is that your brain would be a survival maximizing organ, not a truth maximizing organ. And because there's no necessary connection between what's true and what enables you to survive, there's no reason to have any confidence that your brain is actually reliable to make judgments about what's true and false. And so this is an introduction to a very complex argument, obviously. Alvin Plantinga is the Christian philosopher who is probably best known for this. It's called The Evolutionary Argument Against Naturalism. And if you read his book, Where the Conflict Really Lies, This is a book about the relationship between science and faith. He lays out the case for this argument, showing that if naturalism was true, you couldn't possibly know it to be true because the brain would be the product of an unguided evolutionary process in beautiful detail. But simply the point is here that if secularism is true, we have no reason to be confident that our brains would function effectively for what we want them to function for. And Charles Darwin himself recognized this problem. He wrote in a letter to a friend that, "With me the horrid doubt always arises whether the convictions of a man's mind, which have been developed from the mind of lower animals, are of any value at all, or at all trustworthy. Would anyone trust in the convictions of a monkey's mind, if there are any convictions in such a mind?" And Nietzsche, who's always very quotable, wrote, "Only if we assume a God who is morally our like, can truth and the search for truth be at all something meaningful and promising of success. This God left aside, the question is permitted whether being deceived is not one of the conditions of life." So then you have brilliant secularists recognizing the consequence of their belief system for their whole approach to deciding what's true and false, and the deep uncertainty they're left with. So, we've argued that worldviews profoundly and unavoidably influence medical decision-making. I've tried to make the case that there's no reason for secular humanism to be the default position for the practice of medicine because of all the issues that we've covered in terms of it being religious and in terms of it being self-refuting with respect to patient value and with respect to knowledge. So that entails that it's reasonable, at minimum, for your Christian worldview to be the foundation on which you practice medicine. And it's reasonable also for your patients' medical decisions to be made in light of their own worldview. So what does the Christian worldview entail for the practice of medicine? Well, this is a massive topic. Hopefully, it sounds like Lester is actually going to begin to address it in his next talk. And I don't have time to really get into this in depth. But I do want to point out two specific issues about the way that Christians see the world that influences profoundly the practice of medicine. The first is the way that we as Christians see the patient. When the Genesis text tells us that we are created in the image of God, in the ancient Near Eastern mind, that meant something very specific in terms of being a subordinate ruler, a representative ambassador functioning in the place of a distant king or lord. And there are many ancient Near Eastern documents that you can cite that use this kind of language with reference to subordinate rulers or vassal kings who are in covenant with a greater king. And so in using that imagery or that language, the Genesis text is communicating that we are appointed as royal rulers over creation. We have that regal status. And yet we live in a broken and fallen world as a consequence of our rebellion against the one who created us and appointed us to this royal rule. And Blaise Pascal, the French Christian philosopher, described the human condition as that of deposed royalty. So when we go to the bedside, when we go to touch the patient, when we go to talk to them, I find it profoundly significant to think of the person in front of me, the person in the bed before me, as deposed royalty. Someone who was created to rule and to govern with God over creation, and yet because of the consequence of sin and rebellion, death and disease that we all live with, here they are now under fate and dealing with the consequences of all that. And yet still they retain that royal status. And Jesus' goal in coming to redeem humanity was to restore us to that rule. So to me, this powerfully ennobles our view of the patient. The patient is deeply significant. Of course, we also see the patient as body and soul. And of course, there's some discussion within Christianity whether humans are just bodies or bodies and souls. I think the long-term orthodox and rational view is that we are both bodies and souls. That's a conversation for another time. But what that entails is that we don't just have physical needs or emotional needs and psychological needs, but also that we have spiritual needs, and health and wholeness cannot just focus on one of those aspects, as Alvin and I were talking about today. It has to cover the entire nature and constitution of what a human being really is. And that relates also to our Christian vision for health. For us, health is not merely the capacity to live the life that you want to live, that you subjectively desire. We have a much richer view of health. And perhaps it could be summed up in the biblical term shalom, which Tim Keller defined as a rich state of affairs in which natural needs are satisfied and natural gifts are faithfully and fruitfully employed, all under the arc of God's love. This is the vision for what it means to genuinely be alive, to live in community, in shalom with others and with God, and out of that life of love to express the gifts and talents that you've been given. And of course, sickness and disease seriously interfere with our ability to exercise that God-given vision for living in shalom. And so our role as physicians is to help restore people and to enable people to live in shalom even in the face of their illness, knowing that because we live in the already not yet, we can only give people a foretaste of shalom. True shalom ultimately comes upon the return of Jesus. Paul in Romans wrote that the kingdom of God is righteousness, peace, and joy in the Holy Spirit. And this is the vision of health that we as Christians share together. Many of you may have heard this statement by Thomas Sydenham. It's quoted on the Christian Medical and Dental website. And I actually have this statement hanging in my office because to me it is a profoundly beautiful description of what it means to bring Christian faith to bear on the practice of medicine. I'll just read just one part of this, where Sydenham writes, "Secondly, that all the physician's skill and knowledge and energy as they have been given him by God, so they should be exercised for God's glory and for the good of mankind and not for mere gain or ambition." And how different that is than the culture of medicine that we're so tempted to practice in, where too often we ourselves are driven by ambition, by desire for personal gain. We have to continually repent of falling into that temptation and instead exercise our gifts for the glory of God and the good of others without any pursuit of mere gain or personal ambition. Of course, this understanding that worldview shapes medical decision entails a certain respect for the patient. And it means that we will be very loath to try to impose our worldview on the patient and to respect the way in which the worldview shapes the patient's goals and values. That doesn't mean we're going to do anything that they ask us to do. It simply means that we're going to try and afford them the freedom and the room to make decisions within their that reflect their worldview. And so that may often mean being willing to let them go and find another physician who will provide the care that they want if our worldviews are fundamentally in conflict. But this so obviously is a way of respecting who the patient is as deposed royalty. All right, so I'm just going to move to the end to conclude. I've tried to argue that worldviews matter in medicine, that the secular humanist worldview doesn't have any grounds for being the default position. And so it's very reasonable for your Christian worldview. And so we need to spend time together thinking about what does it mean to be a Christian in medicine? What does Christian-shaped medicine or Christ-shaped medicine or gospel-centered medicine really look like? And how do we go about delivering that kind of care? And in a way that also respects the patient's freedom to hold to their own worldview. So lots of areas where I recommend some reading around this, and happy to take any questions that you might have. Thank you for your time and attention.